Good afternoon, good evening, good morning to all of you who have joined in from various parts of the globe. Welcome to the first of the HSTP HPSR webinar series, which is on systems thinking for health system strengthening. My name is Shilpa John, and I am a specialist with the India Health Policy and Systems Research Fellowship Program that is anchored here at the Health Systems Transformation Platform.
HSTP in short. HSTP is a non-profit organization which works in the areas of health policy, service delivery, financing, governance, and health systems research. So thank you all so much for joining us today. Before we begin the webinar, a few housekeeping rules. This session is being recorded, and we invite you to share the questions for the panelists in the question and answer box. And we also would encourage you to share your name and affiliations in the chat box. So now I would like to the agenda for the program today. We will begin with opening remarks by Dr. Devadasan, and then move on to to our keynote speaker, Professor Lucy, and then move on to the section where we have an experience sharing by our mid-level researchers, and then have a moderated session, Q&A session. So I urge you all to do type in your questions into the Q&A box so that we can start taking it up. Now, to begin the program, I would like to call upon Dr. Devadasan. Dr. Devadasan has worked for over 3 decades as a public health professional. He started his career as a community health doctor in the forests of Nilgiris, where he built a comprehensive health system for them. And since then, he has worn many hats. He has worked with the WHO. He's worked at HSTP. He is the founding director of IPH, and he has headed many research projects, including 2 large multi-country projects. Dr. Devadasan, over to you. I would request you to share your slides, please.
Thank you, Shilpa, for the kind introduction. Can you see my slides? Okay. Good afternoon to everybody, but I see a lot of people from outside India, so good morning, good evening, whatever it is. So it's my pleasure to welcome Lucy, Professor Lucy Gilson, and allow this opportunity for her to share with us her experiences in systems thinking and help us understand it much better. Before we go into systems thinking, I just would like to take a few minutes to talk about systems, health systems per se. The reason is that in India, whenever I talk about health systems, most people think of health systems in terms of either the government health services, or you mean the government health services, or some people say, okay, you mean the government and private health services. So they limit the word health system to these 2 domains. When you talk to the people within the health services, even it's government or private, they will say, oh, the system does not allow me to do it, which means basically the management, the hierarchy, their superiors do not allow me to do it. So that is the kind of confusion that we have in India. I don't know in other countries, but in India, we see this sort of confusion of what is a health system. So I thought I'd just clarify that systems, actually systems and health systems is from engineering science and management science. It has been there for a long time. It's been come into the health sciences very recently. Essentially, when you talk of a system, we are talking of elements which are interconnected for a particular purpose. So it's not just random elements and which are floating around, but they are interconnected and there is a purpose to it. So if all of us know this thing of computer system, I mean, these are words which we always use. So elements are your CPU, your screen, your keyboard, etc. connections are the wires and the Wi-Fi signals, electricity cable, etc. And then the purpose is, of course, maybe to store material or to communicate with others. So this is an example of a system, but this is a mechanical system. When we talk of social systems, we talk of similar things, but only that it deals with people. And now when we come to health system, the WHO in all its wisdom has defined health system as all the activities whose primary purpose is to promote, restore, and maintain health. The key word here is primary purpose. So if you look at, again, from those three things of a system, what are the elements, what are the connections, what are the purpose? So these are some of the elements we can easily identify what is called the building blocks of a health system. This can be health financing, medicine, etc., etc. This thing, I think many of you all may have seen this, these elements, building block. This thing. Again, like I said, WHO in its wisdom has said, listen, while water and sanitation, food, environment, and all determine health, but their primary purpose is not to promote and restore health. So they put boundaries on these elements and said, let's focus only on what they call 6 building blocks. So that's the why today most of us talk about the 6 building blocks of a health system. But it still is not cast in stone. Many people will talk about other elements which can come in, etc., depending on their context. Now, this is where the fuzziness comes in. What are the connections between the elements? And as you can see, it looks like one mess, and it is a mess in the sense that every element is actually interconnected to the other. So what happens with health staff will affect the medicines and vice versa. What happens in information systems affects the infrastructure and vice versa. So everything is interconnected. So these are not standalone building blocks. And I think all of us in this domain are trying to come up with a very neat diagram which can illustrate this, but because it is so fuzzy and not clear, we have all failed. This is my best attempt at this thing. So this is, the idea of this is that each of these blocks will affect the others, and there'll be multiple blocks can be affected, etc. Now the last one is about the purpose of the health system. And here we talk about the purpose, which is basically universal access to quality of care. The health system should be responsive to the needs of the people, improved health status, of course, and financial and social protection. So with this introduction, I would like to stop and hand over the topic on systems thinking over to Lucy. Yeah, thank you very much.
Thank you, Dr. Devadasan, for setting the tone of the webinar today and the very purpose that we have come here to discuss. Now, we all know that Professor Lucy needs no introduction, but we are delighted and thrilled to have her with us today as the first speaker who is starting, as we start off with our webinar series. But nevertheless, I'll make an attempt. Professor Lucy holds the appointment of professor both at the University of Cape Town and the London School of Hygiene and Tropical Medicine, UK. And she's also an honorary professor at the University of Witwatersrand. Throughout her career, her research has been driven by a concern for equity in health and healthcare. And this has involved conceptual and empirical work on issues of healthcare financing, organization, management, and policy change. In fact, today we come from a session where we have had the incoming cohort, and we start out right from the reader which Professor Lucy has edited, which is so often quoted. Professor Lucy has also played a leading role in developing the field of health policy analysis, and she manages a Continental Initiative to strengthen training in this field. And she has also conducted collaborative research with colleagues in other countries in Eastern and Southern Africa and in Asia. I would like to call upon Professor Lucy for her keynote address, please. Over to you, Professor Lucy.
Thank you very much indeed. Let's just get the the slides up. I'm very pleased to be here, and thank you so much for the invitation. Thank you also to Dr. Deva for a great introduction to health or to systems and to systems thinking. So what I intend to do is use a systems lens to think about what health systems are and what that systems lens means for how they can be strengthened. And then I'm going to, at the end, present a couple of relevant research examples. Let me just check before I go on that you can hear me, Shilpa, that everything's okay.
Yes, absolutely.
Great. So in thinking about the systems lens, I want to introduce two principles of systems thinking. And the first is the need to think system-wide. So what does that mean? Well, the definition of what a system for population health is directs our attention to a wide perspective. On the health side, we need to think beyond individuals and beyond sickness to broader health and social well-being. And on the system side, as Dr. Deva has already said, we need to recognize that a system is a collection of parts interacting towards a specific purpose. Now, in health systems, the WHO building block framework up at the top right is quite widely used, as Dr. Deva has already said, and it reminds us that a health system is more than service delivery. It has a number of different elements that are dynamic and interconnected. And in the diagram at the bottom right, a version of that building block diagram also reminds us that people are part of every system. And so we need to think about people as we think about systems. So what does thinking system-wide mean for how we think about health system strengthening? So let me take the example of introducing a new vaccine into a system, something that countries around the world have grappled with in these last years. So that's an element of change in the service delivery building block. But to enable the delivery of a new vaccine, it's important to think about all the other elements of the system. We have to consider whether the vaccine supplies are going to be adequate, whether they're appropriately distributed across a country or a state. We need to think about whether any new staff are needed, whether there's training needed for the staff, and we need to think about how motivated staff are to deliver care. And of course, we need to think about funding, whether there is additional funding required for vaccines or any of the linked activities and costs. But it's also important to think about information. We need to gather information to track the performance of the rollout process. We need to monitor and guide future implementation. And when we think about people, it's important that we think about the people we serve. What sort of public communication is needed to provide information on the vaccine, on side effects or concerns about side effects, and so on. But it's also important to think about communication with health workers themselves and with people working in other sectors who might be involved in vaccine rollout. And finally, we have to think about the issue of governance. Who's going to coordinate all the actions needed to support rollout? What continuing engagement and consultation is needed with which groups to support vaccine rollout? And what sort of support is going to be provided to the process of rollout so that we can learn from challenges and strengthen implementation as we move forward? So when we think system-wide, one implication for system strengthening is the need to strengthen the platform that is required for service delivery. But we also need to recognize, when we're thinking about health system strengthening, that thinking system-wide requires us to acknowledge that improving population health requires more than healthcare. It's not just about service delivery. And the body of global evidence indicates and illustrates that to improve population health, we have to think about how to strengthen local level action, to encourage social empowerment, community empowerment, and to enable intersectoral collaboration. So a thinking system-wide approach gets us into thinking about engagement with communities and engagement with other sectors. But let's move beyond that first principle of thinking system-wide. The second principle is to think about thinking system deep. And system thinking demands that we think about linkages and relationships within the system, the interactions amongst system elements and the people of the system that are what brings a system alive. So firstly, what sorts of interactions and relationships are important to acknowledge? Well, I like to use this framework of a health system drawn from the work of Julio Frenk, who was the former Minister of Health of Mexico. And it identifies groups of actors in any system, providers, population, other sectors. Resource generators means those who train human resources. It includes financing intermediaries. And of course, public governance structures that are charged with coordinating and ensuring regulation of all aspects of health systems. But what this framework does is remind us about the interactions. It has many different arrows on it to show the connections between the different agents of the system. And the words in purple highlight some of the types of interactions. So other sectors offer services with health effects. The population can engage with healthcare providers through mechanisms of community participation. But what I particularly like about this framework are the words in red, which speak to the relationship between healthcare providers and the population at large. And they talk about an aspect of health systems that is to do with the meanings that are made within health systems about what they are and what they do. And in this instance, that phrase, schemes for interpreting human experience, emphasizes that in the way that providers interact with their patients and the wider population, providers make meaning of patient needs in certain ways. So as biomedically trained providers use a biomedical lens to interpret what patients tell them about their history, their symptoms, and then they offer treatment based on that lens. But if you were to go to an Ayurvedic provider, or as in Africa, to a traditional healer, those providers would use different schemes to interpret human experience. And those schemes would direct them to understand ill health and health in different ways. So when we're talking about the interactions within a health system, it's not just about the obvious connections between different agents. It's also about the way we understand each other, the mindsets and thinking processes we bring to our activities in the health system. And in this case, the arrow between providers and population is one way, from providers to population, emphasizing that providers are in a position of power relative to their patients. And that's an important dimension of the interaction to acknowledge. Let me also just give another example of interactions within any health system, focusing here on the sets of interactions between supervisors and health providers and between health providers and patients. And the intention of this slide is to demonstrate that those interactions are interconnected. So depending on how the relationship is between supervisors and health providers, the relationship with providers and patients will be affected. Where supervisors and providers treat each other with respect, where there is courtesy, where there is support and engagement, then it is more likely that providers will also treat patients with respect, courtesy, and engage them appropriately in thinking about treatment. But where the reverse happens and there is disrespect in the supervisor-provider relationship, then it may well be there is disrespect in the provider and patient relationship. And that has long-term consequences. Those interactions of relationships have long-term consequences for quality of care and for equity of access, because there is a feedback loop between them. So looking beyond the types of interactions and the types of relationships, we also have to ask, when we are thinking about systems, what shapes the interactions and relationships? What leads them to work in particular ways? And systems thinkers often use the metaphor of an iceberg to remind ourselves that what we see in any system is only a small part of the entire system. And much of what drives how a system functions lies beneath the surface. And in an iceberg, most of the iceberg lies beneath the surface of the water. And we rarely understand how big it is, how deep it fits, and what's going on there. So the thinking deeply systems thinking principle requires us to interrogate what's lying beneath the surface of any system. And in thinking about that phenomena, that complexity, I want first to draw on organizational theory, which indicates that when we think of any organization, and that could be a specific health facility, it could be a public or private facility, or it could be a network of facilities, that the visible part of the organization is, for example, the statement of mission or the organogram, the job descriptions that people have, the standard operating policies that are the rules that are intended to drive the organization. But organizational theorists remind us that there is a lot that goes on in organizations that we don't see, that is invisible, that is part of the daily life of an organization, but is not acknowledged formally. And that includes the way people interact with each other. It includes the informal networks that gives certain individuals power, even when they aren't formally given managerial power. It includes the way we feel about work, the meanings we make at work of what we're doing, of our relationships with others. It includes the organizational culture that shapes the way people work together. Now, in the work that I've done, we've translated those ideas into saying that when we think of health systems, we have to think of three dimensions of health systems that interact: the hardware, which includes funding flows, the level of human resources, infrastructure, and the software. And the software itself is comprised of two elements. Tangible software includes management knowledge and skills and processes such as budgeting and planning processes. But we also have to acknowledge those intangible software elements, similar to those I discussed in the invisible organization, the power relationships, the cultures, the ways of doing business that shape the interactions amongst agents. And when we're thinking what lies beneath the surface of a health system, systems thinkers remind us that we also have to acknowledge that a health system, like other complex systems, is an open and nested system. You may work in a hospital ward, but that ward is located in a hospital that is part of a referral network, that is managed by a bureaucratic agency, that is part of the array of services and actors within the national system, that is rooted in the national context, and that is influenced by the global context. So the people working in a ward are open to multiple influences from history, sociocultural context, political and economic pressures. For example, the gender dynamics at play within any health facility are rooted in broader societal experience of gender dynamics. The priorities of any health system are rooted in broader political pressures. So when we come back to the system iceberg, having thought about the factors that influence interactions amongst agents, whilst we may see the building blocks as what the system is, they only tell a small part of the story, because what lies beneath the water is the human dimensions of every health system, the people and the teams, the engagement with communities and other sectors. And those people and teams are influenced by rules, policies, and structures, but not only by rules, policies, and structures. They're also influenced by cultures, norms, assumptions, beliefs, power dynamics, and by wider histories and socio-political and economic circumstances. So what's the implication of thinking system deep for health system strengthening? Well, it directs our attention to different types of health system strengthening interventions, such as decentralizing power within a system, such as establishing mechanisms of mutual accountability, the importance of distributing the power of leadership and acknowledging that everyone in a health system can be a leader, can encourage others to work collectively towards the overall goals of the system. And it includes purposeful interventions to promote the change in organizational cultures that are needed to encourage teams to work together. And those sort of interventions take time and persistence to implement. We need to think about health system strengthening as beyond an intervention in any one of the building block areas, but as a complex process of adaptation and development that has to work across the multiple nested levels of a system and that has to engage multiple actors. So I want finally to turn to some examples of health policy and systems research that applies a health systems lens. And I want to start by emphasizing that this sort of work, research work applying a systems lens, it's not only about the focus of the work, it's also about the way we do our research. And in the examples I'm going to present, they are both examples of research that was conducted with colleagues who are and were managers within the health system of focus, and collaboration with managers, with communities in doing research is a part of applying a systems lens. So the first project I want to talk about was conducted in the province in which I live in South Africa. A province is equivalent to a state in India. It's the Western Cape province. And this particular project was conducted collaboratively between a research team and a group of health managers in the Provincial Department of Health with a network of a wider array of managers. And we were trying to understand how this provincial health system had changed over a more than 20-year period and what had enabled that change. It's important to start by reminding you that before 1994 in South Africa, healthcare was politicized in every sense of the term. Healthcare was an instrument of the policies of the apartheid governments before 1994. And the consequence for the health system was a lot of fragmentation, great inequity and iniquity, inefficiency, and a lack of democracy in the system. So that was the situation in 1994 in all provinces, including in the Western Cape province. But in the Western Cape province, over the 20-year period that we were examining, we were able to demonstrate and observe and illustrate how the province had moved from the system of a very hospice-centric public health system, fragmented across multiple authorities, where institutionalized racism was a feature of the system, how it had moved from that sort of non-health system to the development of a coherent, organized array of health services in a system that recognizes the need to address the wider social determinants of health and that engages with private providers as part of this system. And our question was, how was that process of transformation possible? And in the work that we did together, we identified first the system-wide actions that had been implemented, then these covered a range of the system building blocks, the establishment of a single organizational authority to manage provincial health services and to be a steward for provincial health. And there were also actions to do with facility development, to do with human resource cadres, drug innovations, and of course, securing budget. But that isn't only what happened. In addition, if we get a little bit deeper, now turning to the top left of the slide, there were also efforts to decentralize managerial authority across the province. And importantly, efforts to develop financial and resource management processes that enabled new managers to manage resources well and to remain in budget and to use budget efficiency. And these are aspects of the tangible software. But we also have to dig deeper than that. And in this province, in this time, and there were real efforts, firstly, to address the legacy of institutionalized racism, but moving beyond that, to promote person-centered care through deliberate organizational culture change interventions and through the deliberate promotion of distributed leadership across the system. And looking beyond those three features of the system, we also identified how important it was that over the period of focus and subsequently, there's been leadership stability, consistent vision, and careful political management of the interests and actors involved and affected by health system development. And the implications of this study include the reaffirmation of the importance of software to health system development, but also the acknowledgement of the need for sustained leadership of processes of change. It takes a long time to bring about change in health systems. And because we conducted this work collaboratively, the study itself fed into the Western Cape Department of Health's continuing focus on bringing change in organization culture and strengthening governance and service relationships. The second example I want to briefly present arose out of a period of collaboration with health managers at a local level in a what's called a sub-district area of the city of Cape Town, where a research team had worked for a long period of time with the managers, both to better understand their realities and to work with them to strengthen their management activities and processes. And this paper reports one analysis from that work. We called our work Learning Site Work, Processes of Co-Production. The particular analysis I'm referring to on this slide sought to understand how the local level managers responded to the chronic stress in their environment, in particular to an organizational restructuring of the authority, the local government authority in the area. And this was pre-COVID, and we sought to understand how they responded and how their responses provided insights into health systems resilience. And what we saw was that what was important were the leadership practices and organizational routines in the system, as highlighted by the dotted red circle on this slide. The picture represents our conceptual framework, and the findings speak to the importance of leadership practices and organizational routines. And the implications of this analysis are to really affirm the critical role of mid-level managers, the managers who are halfway between the center, whatever that is, and the periphery. Their important role in buffering central demands, in reframing central demands for their staff, in managing upwards to address concerns of staff, and in their everyday practices of leadership, the way they conduct supervision, the way they establish meetings, the way they engage their staff, how those everyday practices help to nurture resilience in the system. And this study, conducted again with local managers, has fed both back into their own leadership practice, into wider understandings of leadership, and to our wider work of leadership development for the health system in South Africa. So let me finally end with the words of a well-known system thinker, that the importance of systems thinking is that we can use it to understand how things work, to identify the root causes of problems, importantly then to see new opportunities, make better decisions and adapt to changing circumstances. And I would argue it's the collaboration between researchers and decision makers that can help bring that opportunity alive. Thank you very much.
Thank you so much, Professor Lucy. That was very inspiring, very well evocated, and I think the key takeaway, especially also what we've also been discussing since morning with all our fellows, that how people actors, they are at the very heart of all our interventions and all our activities which are geared towards strengthening the health systems. And now we will move on to the next session. I would also take this opportunity to remind our attendees to kindly type in their questions. We have a few coming in now, which we will take up after the next session. So for the next session, we have an experience sharing session where we have a few of our colleagues joining us. They are mid-career researchers themselves who are grappling with the concept of applying systems thinking in their various areas. And for this session, we will have Dorothy Lal, who will be moderating the session for us. Dorothy is a medical doctor by profession. She is a faculty at the CMC Vellore, and her interests are in primary healthcare and care for chronic non-communicable diseases. And I'll also take this opportunity to introduce our colleagues who will be speaking next. We will have Harsha first. Harsha is a program officer at the India Primary Care Initiative, and she is also an India Health Policy and Systems Research Fellow from our first cohort. Then we will have Dr. Sudha coming in. Dr. Sudha is also working with the India Primary Healthcare Initiative, and she is an HPA fellow herself from the 17-18 cohort. And then we wrap it up with Ankita, who is a qualitative researcher at the George Institute for Global Health, India. And she also is a fellow from the first batch of the India Health Policy and Systems Research Fellowship Program anchored at HSTP. Over to you, Dorothy.
Thank you so much, Shilpa. Maybe I could invite Harsha then to share her presentation with us first.
So, hello everyone. Can I please request for my presentation to be put up? Shilpa?
Yes, Harsha, I think they're just pulling it up.
Okay.
Wait a few seconds. Yeah.
So, hello, hi everyone. Thanks, Shilpa, for the introduction. So I'm Harsha, and as Shilpa said, I'm in the first batch of it. I was India HPSR fellow, and this is where I got chance to apply HPSR lens. And I am an early career researcher, and let me acknowledge when I say early, this is my first attempt to use HPSR lens, and my earlier work experience has always been in the implementation. So basically, I'll be sharing some of the confusions I had and some of the learnings while I arrived at the research question for this specific project. So next slide, please. So the research interest area in my mind was primary healthcare and how it is related to health equity. What I wanted to see was how primary healthcare initiatives influence health equity. So now, as we know, health systems always have the goal of improving health equity, and especially primary care is associated with improvement in health equity. The particular initiative which I had in mind was Health and Wellness Center. Let me just briefly talk about what Health and Wellness Center initiative by Government of India is. So it started in 2018, and it is kind of a reform and change in organization of service delivery, where there is more focus on primary healthcare, and the existing primary healthcare facilities are getting upgraded to provide comprehensive primary healthcare. So what I wanted to see was how the policy articulation of health equity is getting translated into implementation when this initiative was rolled out from 2018. Now, while learning HPSR during the fellowship project, I understood that I can approach this question by understanding health and wellness centers in different forms. So I can perceive health and wellness centers as a facility, which is a usual notion among program managers, and especially in my earlier work experience also, where I was working in a government agency, and I was involved in the implementation of this program. So I could consider it as a facility and then see what are the health outcomes when this program was implemented. Now, when I got introduced to the system thinking lens, I looked at health and wellness center as a system level intervention, where there are inputs in the forms of more human resources available at primary care level, more funds available, more medicines and diagnostics to take care for chronic diseases, and moving forward from the RCH-centered care, or use of IT systems. So as you can see, it was I can picture the health and wellness center as a system level intervention along all the system building blocks, which Professor Lucy just explained. But to see how this is related to health equity, I realized that it is more of the interaction between these building blocks and how these are governed will be important to see. And again, to zoom it out, I thought of approaching health and wellness center as a policy or as an idea, as a governance level intervention, which can influence health equity. And I thought that maybe to see how these two ideas, the idea of the primary healthcare reform as health and wellness center and another idea of health equity is related, will be more relevant to see. And there was a research gap there. Next. So as I said, in my earlier work experience, I was involved in drafting the guidelines for this newer initiative by Government of India. And I always looked at that document as an evidence-based document, which is helping states to roll out this initiative. And it is just giving solutions. It's a prescriptive document. It is giving solutions to problems which are out there, standing. And this guidance document is going to help it. Now, as I engaged more with systems thinking and HPSR lens, I realized that it's not very, the policies and the problems it is trying to solve cannot be differentiated. So policies are actually defining the problems which they are trying to attempt to solve. There is a certain way in which primary healthcare or the equity has been defined in that particular policy document. And it is important to know that and actually to question the policy itself and how it is influencing the health system. Then I realized that policies are not value neutral. So the language is not neutral. There are certain ideas of equity which have found their place in the document, depending on the power of the actors, the intangible software which Professor Lucy was talking about. So that has influenced certain characterization of equity in the policy itself, while certain equity aspects are left out. So I thought of understanding this characterization in detail for my research question. Next. Yeah, so here the health policy triangle was helpful in articulating the question or clarifying the question which I had in mind. So as we know, this health policy analysis triangle was given by Professor Lucy and Professor Walt itself in 1994, and it has been used in this field a lot. So policy, as we see, is influenced by the complex interrelationship between these content and the actors and a specific context in which it was formed. So next, please. So next, and you can double tap. Yeah. So I thought of understanding this interaction between the content and actors and how this interaction in the certain context has resulted in certain characterization of health equity in the policy document. So what are the implicit assumptions behind the representation of health equity in the policy, and what are certain silences which I can look at? So now that's how I came up struggling with system thinking lens and then going to the policy lens in understanding how health equity can be influenced, it will be influenced by health and wellness center policy. So during this, next please. During this process, I of course faced, not challenges, but I found that finding an appropriate framework or articulating, can you please go back here? Finding an appropriate framework or the methodology for answering this question was, I won't say challenging, but it was difficult for first experience. And also as I struggle with the concepts, it's sometimes it's difficult to even articulate the concepts which I'm talking about, because it seems very much at the conceptual level. And so going forward, I do anticipate the challenge of how I will present the findings from this study and communicate it and make it relevant, not just for the researchers, but also for the policymakers and implementers. It would be great if any of you, Professor Lucy, Dorothy, or can reflect on this particular challenge of mine. So thank you. That's it from my side. Thank you for giving me this opportunity.
Thank you. Thank you so much, Harsha, for not only sharing your work, but also some of your journey and the thinking while dealing with this research question. Maybe we'll next hear from Sudha as well. And then, yes, the question that you posed, we'll wait to hear from Professor Lucy also. But first, I'd like to invite Sudha to also maybe share a little on her work.
I think I'll request the slides to be put back, Shilpa, possible?
Yes, I think they're just pulling up the slides, so that just a few seconds, yeah.
Okay, first, thank you very much for this opportunity to talk today. I'm Sudha, I've already been introduced, and I've been asked to talk about the application of systems thinking. Maybe you could move to the next slide. So I start with something that Lucy had mentioned in her address, that health systems, when we look at it through the systems thinking lens, they can be viewed as much more than just discrete building blocks. The interactions between these blocks matter. And one way of looking at systems is as having hardware, which is the finances, human resources, supplies, but equally important is the software in health systems. And within software, we speak of both the tangible components like training, the formal governance, but we also speak of the intangibles, which we can define, and I've put a definition here, as a range of ideas, the norms, values, also issues of power and trust. And all these affect the performance of health systems. So, and as much as the hardware affects how systems perform, the intangibles, they also influence the way that a system function. So the focus of some of my work has been on the software component, what lies beneath the surface, as the big glacier diagram that we saw earlier. And particularly on, my work has been on intangible software. And one question, I saw a couple of questions in the chat box also, is that, we talk about systems thinking and to rewire intangible software. Is it really possible to do so? How do we do so practically? And conventional approaches, when we think of health systems strengthening, they do not even consider these issues, the intangible issues, as the real issues of the health system. And even when people recognize its importance, the second thing is practically we don't know what to do with, how do you build trust, or how do you engage with power and make a difference? There is something that people are still questioning. Some of my work earlier, when I was working with Oxford Policy Management, we did try to approach this from a very practice perspective. And we tried to see, okay, what are some interventions we can do? And we landscaped some things which have been done in India, for example, relating to leadership or relating to think tank, and, having how to communicate with community workshops, sensitization, or buddy systems where juniors are connected to senior mentors, and see if these things can make a difference to intangibles. I haven't gone too much into the approaches in this presentation, but one question that I do, maybe the next slide, please. Thank you. That people have been asking, people who have tried these different approaches, is that including funders, implementers, is it really worth putting our time and effort into working with intangible software? You know, because for these kind of interventions, it's hard. It has been hard to conduct impact studies because the context matters. You know, everything is embedded in that big context diagram that we saw. And when we roll out interventions, sometimes there's a big time lag. For example, if you have a leadership workshop, people don't become leaders overnight. It's a long process through which they become. We see results for these. And one good example of such an evaluation, which has been in fact been conducted by IPH, Dr. Devdasan and team, and Prashant. And they use this approach called the realist evaluation approach. And they try to see, okay, what can work where and why, you know, and this comes with an understanding that everything, we cannot expect everything to work everywhere uniformly, because as Dr. Devdasan again mentioned, systems are made of people and people are different everywhere. So finally, some of the lessons that we have learned while doing this work is that it really helps to co-design interventions, you know, with people whom they are working with. Dr. Louise Gilson's example of the learning sites, which you had mentioned earlier, talked about so collaboration and how to work. And second one, an understanding that change is hard to bring about. We have to give it time, and there are things which our history matters, where we come from. And in fact, in one of Dr. Kabir Sheikh's and Dr. Abimbola's work recently, he points out that culture eats strategy for breakfast. So changing culture is hard, but if we don't do that, our strategies are not going to work. I think my final point is that although we have separated hardware and software, we talk of them differently. These two go together. And one example of this I can tell from India. So we know that the head of our primary health center is a medical doctor. And now we want to say let's explore PHCs where nurses are the leaders. But to do that, I have to give formal power to nurses. I have to enable them with equipments, drugs, facilities. And not only that, in the end, nurses have to view themselves as change makers, you know, as leaders. They have to get the confidence. So when I look at this sort of intervention, we have to build both the hardware and software together, and in order to make a difference. So I will end here. Thanks so much for listening, and we invite more comments and engagement with this work. Thank you.
Thank you, Sudha, for bringing many of these important issues to the forefront. The questions that you posed are also the questions that are coming through in our Q&A box, and I will pose those to Professor Lucy and to Dr. Devdasan and others to share their thoughts. But perhaps we'll first hear from Ankita as well, and then maybe get into a time of Q&A.
Thank you, Dorothy, and thank you, Sudha. Very interesting presentation, and I'm very happy and privileged to be part of this panel and share some of my reflections here. So maybe I'll initially talk a bit about my background. I'm a qualitative researcher, and I come from the social sciences and health background. And for the past 2 years, I've been part of interdisciplinary teams which are working on 2 large intervention trials, basically testing strategies to improve uptake and delivery of mental health care in primary care settings. And I'm also, as already mentioned, the in 2021 cohort HPSR fellow here. So I think in the next slide, please. Yeah, so my exposure to systems thinking was through the fellowship itself. And I think the initial reflections, because I was part of an implementation research team, I was aware of some of the literature and some of the debates around, when we are looking at interventions, why they work, especially complex interventions, why they work or why they don't work. We must look at context, we must look at mechanisms. But what I realized after this fellowship was, the health interventions that we are testing or designing are meant for health systems that themselves are complex systems. So understanding of health systems as complex adaptive systems was, I think, a big takeaway for me. And also what comes, in terms of systems thinking, the idea that health systems are non-linear, which in other words means that, if you design an intervention, it does not work as, an input or output thing. Things might be quite counterintuitive. So you may design an intervention thinking, oh, this has all the so-called perfect ingredients, but health systems are complex and it may not result to, give the results that you initially thought. So those aspects. And also, I think another key takeaway in terms of systems thinking was understanding how everything is tightly linked, the interconnectedness that everyone spoke about, how the whole system and the subsystems are all interlinked. So I think some of these reflections and understanding of health system really kind of helped me to look at my research. And can we go to the next slide, please? Yeah, so my research problem area is basically to look at how we can integrate mental health in primary health care. Can we go to the next slide, please? Right. So I'll briefly talk about, how system thinking kind of informed my research idea. So here I'll be talking about my research for the fellowship, which is a very small project, in which I'm trying to look at, again, health and wellness centers, which Harsha spoke about. And so health and wellness centers are basically upgraded primary healthcare centers, as Harsha said. And there are a set of guidelines which kind of tell you what should be in place in health and wellness centers, as well as a set of guidelines for different disease conditions, so to speak, about the kind of services and processes that should be in place to provide services. So we even have guidelines for mental health care. So my idea in the fellowship project is to kind of look at how mental health guidelines are being implemented, what are the barriers and what are the facilitators. But I think where systems thinking, when I wanted to apply it to this research, I had a lot of, difficulty, I had a lot of doubts. I was wondering, well, should I use certain methods for it to qualify as systems thinking? Maybe I should use, specific methods for it, or are there specific questions which are amenable to systems thinking, and a lot of other doubts. But I think eventually what systems thinking helped me was to frame my questions and to ask the questions which I would not have asked earlier, which, if you can say, the whole question of system software and hardware, I would not just want to look at, for example, medicines, resources, infrastructure, but also questions of in the intervention, in the new plan, in the new guidelines, they have for the first time decided to include community health workers for screening of mental health disorders. So we already have an existing program for 40 years, which has worked on training doctors, and which has its own, set of histories and baggage and organizational culture and issues. And we have now introduced a new program. So how does that affect this? What are the linkages between these new the new initiatives that have been planned and the old program? Also, how do these frontline health workers interpret the policies and guidelines that are provided to them? And again, in the area of mental health, we know that from a lot of numerous conversations with PHC doctors, I know that mental health is often not the priority. We have a target-driven culture. Mental health has never really been on the priority. So how do those perceptions and ideas about mental health work? How will they work within the context of the numerous services that are supposed to be provided within the health and wellness centers? What will they prioritize? What will they not? finally, within the community, there is a very strong stigma around mental health. And finally, when community health workers, decide to go to the villages and try to do the screening, really, how will that impact the whole thing? So I think what systems thinking has really helped me is to ask certain questions which I would not have asked, conceptualize my research in a different way, and it will definitely help me in explaining and probably making sense of my findings when the study finally concludes. So with that, I'll end my presentation here. Thank you very much.
Thank you so much, Ankita. Thank you, Sudha, Harsha, and Ankita. And thank you very much, Professor Lucy. I'll echo what's already being posted in the chat box about the very nice presentation and this way of thinking that many are kind of wanting to get into and do. So I'll maybe start and hear your thoughts on what the three fellows have presented, and also maybe say what's been coming through the question and answer and the chat box about bringing about this kind of change. So yes, there's social cultural issues, there's a whole lot of contextual issues, there's history, there's a lot of these, the software as we have been referring to it. And changing this is difficult. I think everyone's grappling with that. So I think the question Sudha also raised and came through in Ankita's discussion, as well as what's coming in the question and answers, is about how do you bring about these kind of changes. Professor Lucy.
Thank you so much. And thank you so much for those really interesting presentations. It's great to hear of the work being done. I thought as a first reflection that the presentations all enabled us to see how hardware and software combine and the importance of thinking about those interactions. I think I tend to emphasize the software because we tend to forget that and focus only on the hardware, but it's the interactions that are important. Harsha, your presentation brought alive the ways in which policy itself is complex and is a complex intervention that comprises hardware, the document, the written word, but also the software of the meanings and what the written word actually, the intent and what it says and what it doesn't say. And again, we tend to think of policy as quite an ordered, specific piece of hardware almost in a system. And if we do that, we ignore how it gets translated, how it gets interpreted in ways that were not originally intended. And so understanding policy as ideas is very important in thinking about systems change. I think that the issues of how you then try to bring about change in systems are well illustrated by both Sudha and Ankita in considering how hardware and software interact and what are the elements of a system that bring hardware and software together. And in particular, as Sudha was presenting, it is possible to intervene in the software. It's not easy. It does not bring about immediate measurable consequences in all the things we normally think about. But it is possible. The act of changing organizational culture, the purposeful act of addressing organizational culture, is one that happens in many organizations outside the health system. And if it can happen outside, it can also happen within the health system, but it needs purposeful, deliberate attention over long periods of time. It's not quick and easy. And in addition, I wanted to add, and it reflects one of the comments in the chat, as well as a point that Sudha raised, that in bringing about change, whether it's through the hardware or through the software, we know we have to work with people to bring about change. You cannot simply say to a system, change now. You have to work with the people in the system to gain ownership, to bring change about, to generate change from within the system. And it is always then a process, or needs to be a process, of what some people call co-design, that we are together working out what the problem is and how to address the problem. And the people then who are brought to that task need to be the people affected by the change that is going to be introduced. Doing co-design is not so straightforward, particularly in complex systems with power dynamics. But the act of working together is part of the thing that we need to think about to bring about change. Thanks, Dorothy. I'll stop there for now.
Thank you, Professor Lucy, for that. I think a related question to the change that we would like to see is how do we measure that change? So the example that you showed us was very nice and nice to see. But there's a question in the Q&A about it's obviously not easy to measure. So just your thoughts and some direction into how do you measure this kind of change?
So I think that in health systems work, in healthcare work, we tend to focus on measurable outcomes in terms of either health indicators or service delivery indicators. But the measurable outcome that I see in the system of which I'm a part and in which I live includes things like during the COVID response, this province was able to react quickly, efficiently, effectively, and in the process of reacting, build the way it reacts for future changes. I see it in the way that it continues to promote leadership development, organizational culture change, and is increasingly talking about the role of the public provincial sector in acting as a steward for health, engaging with other sectors, engaging with the private sector, and engaging with the population at large. So in thinking about how you see change in a system, you need to give it time and you need to understand the types of changes that are coming about, not only measure health improvement. And health improvement is not only affected by healthcare or organized health service delivery, it's affected by many factors. So we need to, I think that in health system strengthening, we also need to develop new ways of understanding where we can see change. And that for me will be in some of the processes of focus in change that are intended to leverage longer term change. And secondly, we need to take long term perspectives to see if change is coming about.
Fantastic. Thank you so much for that insightful response. Just related to that, and while we're still on the subject of looking at change, there's another question about measurement of unintended consequences. So yes, there are some that we anticipate and some that we want, but there's also many times unintended consequences of change that we're expecting to see. How do you keep an eye on that, and how do you kind of measure that?
So I think that we can anticipate that there will be unintended consequences because a complex system pops out things in unexpected ways. So the first thing is to be ready for the unintended. And the second is then to start actually in relatively small ways to leverage change in which area of the system is regarded as most important, a big opportunity for change, and then to monitor the change that is emerging, to be able to pick up the unintended, to therefore be able to readapt and change the actual process of implementing whatever is being introduced. So processes of learning by doing are part of what is necessary in bringing about change, because we can expect the unexpected. And therefore, we also need to keep sort of scanning the horizon of what is happening around us to pick up those unexpected issues and then be able to react to them. And I honestly think that's what resilience is about, just to throw that notion in there, that it's not about pre-planning it only, some pre-planning is necessary, but it's about being able to see and react to unexpected change.
Thank you. Thank you so much. While we're still on the subject of change and interventions, I think something that most researchers would grapple with is that there is usually many things that need to be done at one point in time. Most of the building blocks require some sort of intervention or an effort. So just how do you deal with multiple interventions at various levels, and what would your advice to researchers be in trying to think these things through?
So that's a question for researchers and for managers and policymakers and for all of us on this panel. But as a researcher, my response would be that there's an importance in identifying a sort of entry point for understanding the array of interconnected changes and for keeping an eye on a particular element and understanding how it's playing out in interaction with the other components of the system, rather than trying to go very wide and look at everything, because I think it's really difficult to do that. If you're a manager or a policymaker, I would say that you have to have some awareness of the array of multiple interventions, but also acknowledge that the way they're going to interact is going to generate unanticipated consequences. So be prepared for the unanticipated. I think the risk of saying you've got to understand everything that's happening sort of implies that we A, can, and B, we can manage everything that's happening. And I think the complexity in systems thinking tells us that's just not possible. But I think that as a manager, one needs to be aware of the array of factors. As a researcher, I think how we can assist is by zeroing in on an element of change, but then demonstrating how a particular element interacts with other things. And if we're talking about research methods, which a researcher would want to ask, I think that, again, taking a long-term perspective is important. That longitudinal research then of any kind is important, that mixed methods are essential, and in the mixed method mix must be qualitative methods. The last thing is that working with people to understand their realities, so that it isn't the researcher's view of the reality, it's a co-produced view of the reality. Thank you.
Thank you very much. I've taken notes, and I hope the rest of our listeners are taking notes, because I think that's a really nice perspective and thought to keep in mind about the long-term measurement of things, and that this kind of work requires to keep that long-term perspective in mind. So that was extremely useful. Somewhat related, but and maybe not so direct, is a question regarding the way the interconnections between the various blocks using the WHO building block framework are kind of connected. And would you place some higher above than the other? For example, is governance kind of something that dictates all the other building blocks? And therefore, if you were to intervene again as a researcher or somebody as to strengthen health systems, if we want to bring about change, would you then choose one over the other to intervene?
So it's a challenging question for those responsible for health systems, for sure. I think that some people would definitely argue that the governance, the array of processes and practices and structures that are the governance building block, they are intended to coordinate and manage other elements of the system. So in principle, that could be a first place of intervening. But I think if one only intervenes in the governance level, people want to know when is it going to trickle down to service delivery and to community level action and so on. So it's hard to only intervene there. I think the other one that I would say COVID around the world has only reinforced is the importance of information and the not just formal data, but also experiential knowledge and real world wisdom. How important that is to making decisions that then are implemented through the building blocks, if you like. So some people definitely would argue governance and information are critical leverage points, but I think that complexity reminds us that things have to be context fit. And it may be that a leverage point is actually an issue of vaccines, because that's the issue of the moment where change can be brought through. So the task of the policy world is to be sensitive to the context and look for those windows of opportunity in any building block, being aware of how other building blocks would need to change to support whatever the initial change is.
Thank you. Thank you so much. There's also several questions around this notion of power and how do you navigate this, whether it be in the context of decentralizing services or in effecting interventions and bringing about change, power seems to play quite a role. So just your thoughts on how to navigate this. How do you study it? How do you acknowledge it? Just some your thoughts around the notion of power.
So again, I'm sure we've all got experiences of power and can share some thoughts. So I've actively sought to encourage that as researchers, we purposefully inquire into power dynamics and power practices as part of understanding systems and as part of understanding policy change. And it's not easy to reveal power because it is a hidden and an invisible form, and yet we can see it. We know it when we see it, whether it's in the way the doctor treats the patient or the way the doctor treats the nurse, and forgive me, doctors in the room, or the way the man treats the woman. We can imagine various dynamics of power in our own world, and those dynamics are in a health system as well. So sometimes we can see it, but quite understanding it is more complex. But it is possible using relevant theory, using in-depth insights, I would say based on qualitative understanding. I'm not quite sure how you measure power quantitatively. So I think we can reveal it. Then the question is, how do you work with it? And there are definitely others in the room who must have much more experience than I of how you manage power dynamics in policy processes. But the only comment I'd make from my reflection and observation is that every policy process has power dynamics. So actively managing those power dynamics is a part of the task of a policymaker and a policy implementer.
Thank you so much. If any of the others have any thoughts from their experience or from their dealing with some of these issues, please feel free to jump in. Dr. Deva, Dr. Rajesh, or Ankita, Harsha, Sudha, any of the others on this thought of power and how do you manage it?
Can I just
Please
share an example? We were doing a study on health financing, how a particular health financing scheme was being introduced into the community and how effective it was in terms of utilization, blah, blah, blah. And we were looking at the actors predominantly from the top. What was the ministry's stand on it? What was the doctor's stand on it, etc. And we never anticipated, but we found that actually the panchayat member who was holding the cards, the RSBY cards, they were the most powerful because they were deciding who will get the card and who will not get the card. So the instructions according to guidelines was very clear. Once a person, family is enrolled, they have to be given the card within 24 hours. But then the panchayat member holds on to it and says, okay, you did not vote for me last time. So sorry, Tata, next time if you don't vote for me, I won't give you the card. So that entire thing of street level bureaucracy and power by somebody who was not in the entire design of this scheme was really revealing for us. And I think that is something that we have to keep in mind when we are looking at these problems. Yeah,
Thank you for that.
I would like to contribute to this discussion of power. I think it pervades, it is everywhere. It is in our social system, not only health system, and it has been there and it will be there in future. However, we may describe ourselves as very civilized, democratic, etc., etc. But at the heart of it, at the center of it, there is power. There are powerful people, there are wealthy people, and wealth brings power. Sometimes position brings power. Sometimes your status, as a doctor or whatever. So we live in hierarchical societies. And we have, as a human race, we have become very used to this right from the childhood. You see, living with these interrelationships of this kind, our socialization right from the childhood. You see, so to deal with this is not so easy. Maybe just like we in the health system, people have to think of our educational system where obedience, discipline, asking questions is discouraged. You see, so we have to deal with it as a society. Okay, that is a larger question. But coming to health system, wherever we are, and in whatever position we are, you see, if we are like in a position like an administrator or a doctor, or some of us are. So this is who understand this. First thing is understanding this and how to empower all people around us. You see, and listen to people. Listen to people. One of my professors used to say, one day I asked him, that I'm learning social medicine, suggest me some books. He smiled and mentioned, this whole society is the book. This village is the book. Interact with people. Try to understand them. And don't think I am the only teacher. Some people have given me this label of a professor. But this ASHA, Anganwadi worker, this health inspector, they are the ones who are dealing with the problems day in and day out. So,
thank you so much.
Breaking this, this type of hierarchies is not easy. Okay, so but just keep in mind in the analysis that this is there and how we analyze it and how we deal with it, wherever we are. So it's a larger question, but it's an important question.
Right. Thank you. Thank you for that sharing as well as for that example, Dr. Deva. My next set of questions, as many as we can take in the time that we have remaining, are to do with some tips and advices from your wealth of experience. The first one is related to when you said that we need to have the long-term perspective in mind, or we need to be, have a long studies that are over a long period of time. How do you convince policymakers or implementers to wait to see change? Usually they are in a hurry to want to see some tangible results of interventions or, research. But if we're in there for a little longer period of time, how do you convince them to wait for the results?
So I think there are different types of research, and that some research is appropriately conducted and generating findings that are fed back. But I think that if one engages in collaborative work, then you're part of the process as it moves along, and it's actually not about doing the analysis, then writing the piece and then reporting. It's almost that in the process of doing, there's a constant engagement and reflection, so there's an immediate feedback loop into continuing processes. But I think there's a need for a variety of research, and if your study is an intervention trial of any sort, then you need to do the intervention and show whether or not it worked and feed that back. But if you are working in cycles of co-production, then it is possible to immediately engage and encourage, there is a process of learning as part of moving forward. That still needs an initial process of setting up and understanding what the research endeavor will be like, because it is different from how researchers and the policy world understands research. But that needs to be built on platforms of good relationships where you can talk through what it's going to be and adapt what you do as you go along.
Yes, thank you for that. Yes. There's also one question again on how do you capture tacit knowledge? So understanding that that's important, and that may not always be directly there in our research methods, etc. But it's a very important part of what we see. So any thoughts or ideas and tips to capturing this tacit knowledge and making the most of it while we do research in health systems?
Sure. Well, so if we're thinking about intervening in systems, the processes of co-design would immediately capture tacit knowledge, because those are, those folks who have the tacit knowledge are part of the process of determining the problem and thinking how to address the problem. So their tacit knowledge is part of the process of developing an intervention and intervening in the system. I think in processes of co-production, research processes of co-production, it is in the engagement and the thinking together that you then you share your tacit knowledge. So research is then not a process of researchers observing or interviewing or engaging people as subjects, research subjects. It's a process of working together to pool knowledge, and researchers have tacit knowledge to draw on, and whoever one's working with has tacit knowledge to draw on, and in the pooling of it, perhaps the researcher role is then also to document, to distill, to share, because others are busy doing other tasks in the process of change. But it is by working together that you can access tacit knowledge and learn together from it.
Thank you for that. I'll maybe pose two more questions, two last questions. We're coming to the closing time. One very specific question was there regarding strengthening primary healthcare in particular, and where have we perhaps failed in systems thinking? So just your thoughts on whether have we applied systems thinking well enough in strengthening primary healthcare, or if we failed, then where exactly have we kind of failed, was a specific question to primary healthcare strengthening.
I guess I don't know the answer, to be honest. I wonder if the answer would be different in different contexts, different countries and different places. I understand primary healthcare to be a critical way of working as well as a level in a system. And primary healthcare and its importance has long been established. If we go all the way back to Alma-Ata and before Alma-Ata. But the focus on primary healthcare as an important area of or element of strengthening any health system goes through political cycles of interest. And I don't necessarily mean national political cycles. I also mean global political cycles and donor political cycles. So at the moment, we're back in a way, primary healthcare is really important, but no doubt we will move on from that. So perhaps the need is again to take advantage of the window of opportunity of concern, attention, and funding. But in every situation, there may be different things to think about in terms of strengthening primary healthcare.
Thank you so much. So I think this last question is what you have already been telling us, but very specifically, someone asks for many of these things and changes that we want are almost like paradigm shifts. So these are like major ways of thinking that we expect to change or expect to see change in. So just some of your recommendations or best practices, something that you've seen really work on the ground, perhaps from the examples that you shared with us, where, you know, leadership and things like that, you've been able to see a change in. So just some recommendations and best practices.
Gosh, well, again, I'm sure many others have contributions to make here, but I think the starting point is ourselves. Paradigm change begins with our own understanding of the world, and it isn't sort of a fruit on a tree that you can pick and then offer. It is about who one is in the world and how one then engages with the world as a researcher, as a manager, as a health professional, as a community activist. And it is through those engagements that one shares one's understanding, one's ways of working. Having said that, I'm an educator and a researcher. And so for me, the entry points of sharing lie in, for example, the leadership development work that I seek to support and learn through, where embedding a systems thinking approach has been very important. And now I'm learning from the colleagues who are involved in that program, and then in the research that I do and in sharing that research. So we all have a role to play And it starts with our own paradigm change, and then we'll contribute to the bigger collective paradigm change.
Fantastic. What a nice note to kind of bring this to a close. Thank you, Professor Lucy. That was absolutely enlightening and fantastic discussion. Very nice questions. Thank you all who are there in the audience for engaging with this wonderfully well, for your questions, which were all very insightful and enabled us to have such a fantastic discussion. So we end on that note that yes, paradigm shifts and changes and shifts that we want to see begin with ourselves. And I think that's a very nice thought to leave with. Thank you very much, Professor Lucy, Dr. Devathasan, Dr. Rajesh, Ankita, Sudha, and Harsha for sharing your time with us. Over to you, Shilpa.
Thank you, Dorothy. And now to formally conclude the webinar today, I would like to call upon Professor Rajesh Kumar. Rajesh he is the technical advisor at HSTP, and in his earlier avatar, he was the head of department of the community medicine and School of Public Health at PGI Chandigarh. He has a vast experience as an epidemiologist and public health specialist, apart from being an academician. Sir, over to you to formally conclude the program.
Thank you, Shilpa. Good afternoon, Professor Lucy, Dr. Deva, Dr. Dorothy, Harsha, Sudha, Ankita, and all the participants. On behalf of Health Systems Transformation Platform, in short, we'll call it HSTP, I would like to extend our thanks to everyone for their presence and for their contribution to this webinar. System thinking is a kind of a means to understand health systems, and especially to decode the complexity in the health system. And not only knowing, but having known these complexities, we need to think that how we can bring about change, which means strengthen the health systems in our country and participants from other countries. I think this had been a very engaging discussion led by Professor Lucy Gilson. We have been reading about her work in the policy triangle, Jill Walt and she, both for a number of, I would say now, decades. So, and I was one of the early students of Jill Walt in 1990 in London School. So it's really good to catch up with colleagues and hear their names once again. And during my epidemiology course, they asked us to choose one topic, or one course on our own. So I chose this social science because as a medical doctor, I thought I should also know a little bit about social science. So a 4-week course, and in the 4-week, there was 1 week of policy, which was dealt by our colleagues there, Jill Walt and others. But now this field of social science in relation to health system is very, very important. And the methods which was mentioned, this mixed method is something which is very helpful in understanding something which some people said is difficult to understand, these interconnections, how people behave, how they work, and these power relationships, interactions, etc. So it had been a very enlightening experience for me. So I would extend my gratitude to our keynote speaker, Professor Lucy, for taking out time to address our participants on this very important topic. I would also like to thank our young researchers, Ankita, Harsha, and Sudha, who are grappling with their research questions, trying to understand health system. and they also brought out their own perspective. A special words of thanks to Dr. Devdasan, who have been working in the field of health system for a long time and guiding HPSR ecosystem in India, and also Dr. Dorothy Lal, who herself is a young researcher, completed her PhD recently, for steering this discussion very well and gave chance to everybody to ask questions. And in the end, I would say I am thankful to my colleagues in the HSTP, and especially our CEO, Rajiv Sadanandan, for their dedication and support. Once again, thank you all for attending and raising very important issues about health system and systems thinking. I am told that about 300 participants had, registered for this event. Thank you very much for participation. I wish you a great day ahead. Thank you very much.
Thank you, everybody. Goodbye. Good day.
Goodbye. Thank you very much, everybody.